Good morning. Welcome to the second day of our October 2013 ACIP meeting. As mentioned yesterday, in terms of unfinished business, I'll have Dr. Deb Wexler come up to the microphone for a public comment from the Immunization Action Coalition.
Okay, thank you. Hi, I'm Dr. Deborah Wexler, Executive Director of the Immunization Action Coalition. We receive funding from all the vaccine companies pretty much, and we're proud of it and happy about it. And also from the Centers for Disease Control and Prevention, several foundations, and many private donors. I'm here today I wanted to let ACIP and all of you know about IAC's new campaign. It's called Give Birth to the End of Hep B. And the campaign is based on the ACIP recommendations of the year 2005 to make sure that all infants are given the birth dose of hepatitis B prior to hospital discharge. The reason we're on this campaign is because right now, about 1 out of 3 infants are not receiving that birth dose before they leave the hospital. And this is resulting in approximately 800 babies getting infected, becoming chronically infected with hepatitis B during that first year of life. So this campaign is to help stop that. What we've done is created a book. It's about 85 pages long of a resource guide about what you can do, what hospitals can do to protect newborns. And it's been endorsed by the Centers for Disease Control and Prevention, the American Academy of Pediatrics, the American Academy of Family Physicians, and the American College of Obstetricians and Gynecologists. And it's available free on our website for the Give the Birth Dose campaign at immunize.org/protect-newborns. And I hope you'll look at it. And in addition to creating the book and materials to help hospitals and educate them about the recommendations, because what we found is that a lot of hospitals aren't aware of this guidance to give the birth dose prior to discharge, and that it's a recommendation of all these professional societies and CDC. We've also created something called the Hepatitis B Birth Dose Honor Roll. And what that is a listing on IAC's website of hospitals that have implemented policies to give the birth dose to every newborn prior to hospital discharge. And it's to honor those hospitals that have achieved a 90% or greater rate of vaccinating all newborns before hospital discharge. And I'm happy to say that this was just launched in July, and we just started adding more hospitals in September. And we have 20 hospitals right now that we've honored on our website who are achieving the rate of 90% or more over a 1-year period, and who have written policies in place to give the birth dose. So if any of your hospitals qualify for the birth dose or would like to find out more about the birth dose honor roll, I urge you to look at the website, which is immunize.org/protect-newborns. And I hope we'll see many, many more hospitals on the honor roll. Thank you.
Thank you, Deborah. I just want to give generic thanks to all the participants here for just wonderful discussion yesterday on both the pneumococcal and the herpes zoster issues. I think the information was very useful to our working groups to take back for further consideration. Our next topic, we have the pleasure of introducing John Abramson, who will be talking on global immunization issues. Dr. Abramson is on the faculty at Wake Forest University School of Medicine. He's been there since 1981 and serves as the chair of the Department of Pediatrics and physician-in-chief at Brenner Children's Hospital. That's since 1996. Dr. Abramson served as the chair of the American Academy of Pediatrics Committee on Infectious Disease. And from 2003 through 2007, he was a member of ACIP, serving as chair from 2005 to 2007, right here at this location. Since 2009, John has served as a member of the World Health Organization's Strategic Advisory Group of Experts on Immunization. and as of September 2013 has served as chair of SAGE. And this has taken him down the route of serving as chair in a lot of different contexts for SAGE, including the cholera vaccine, meningococcal vaccine working groups, and participation with rubella and global vaccine action plan. So currently he chairs the varicella vaccine working group, a member of the influenza, seasonal, and pandemic vaccine working group, and serving as, or on the technical scientific and technical advisory group for the Global Alliance for Vaccines and Immunization. So welcome, John, and we appreciate your willingness to come.
Good morning, and it's great to see so many old friends here, and I don't mean old, but I guess we all are getting there. So I think that what I'm going to try to do is give you a little bit of where things stand right now globally, mainly over Millennium Development Goal 4, which is decreasing deaths in children less than 5 by 2/3. And remember, those were created in 2000 for a goal of achieving that in 2015, so we're moving there pretty quickly. And the data that used that comparison on 1990 data as the baseline data. So after that, I'll give you a feeling for how SAGE functions and what its role is at the World Health Organization and also in making global recommendations, which go to the Director General. And I'll try to take you through the last 3 years of what we've accomplished. I'm going to show you what we're working on now, but I'm actually giving more of that talk tomorrow to the Global Division about. But I'm happy at the end I try to leave some time to answer any questions that you have. So, so I have no conflicts. So the 8 Millennium Development Goals that the world is functioning under right now set a bold vision for the entire international community to work towards a common end so that UN development reaches everyone. Many of these goals are only partially health specific. Some deal with education, some deal with poverty, but I really don't intend to go through all the goals. But they were adopted by over 190 countries in 2000. As I said, they use 1990 data as the set point. They have 21 quantifiable targets measured by 60 indicators. And if all the Millennium Development Goals are achieved, world poverty would be cut in half, and that's already occurred. That goal has been met. And tens of millions of lives would be saved. And millions of lives have been saved, but we're not at that 10 million yet. Oops. Old habits die slowly. So again, as I said, the goal is to reduce deaths in children less than 5. And in 1990, the mortality rate in children less than 5 years of age was 160 per thousand in low-income countries, as compared to 8 per thousand in developed countries. By 2012, the mortality rate in low-income countries was reduced to 88 per thousand in children less than 5 years of age, a 45% reduction, so not at that 2/3. Global deaths decreased from 12 million to 6.6 million. Because of this, or as part of this, 17,000 fewer children die each year in 2012 than did in, die every day, in 2012 than did in 1990. But still 18,000 children less than 5 years of age still die every day in 2012. Many of these deaths that are still going on are still vaccine preventable, and that's where SAGE spends almost all of its time. This gives you an idea of the recent data on what the death rate was per 1,000 live births in 2012. As you can see, most of the issues are in Africa, there's no surprise, and Asia. So, to date, we've saved 90 million lives. but 216 million children have died before age 5. If we achieved our Millennium Goal on target, on date, we would save an additional 3.5 million children's lives in the next few years. If current trends continue in all countries, the world will not meet the Millennium Development Goal targets until 2028. So what is SAGE and how does this function? SAGE stands for Strategic Advisory Group of Experts on Immunizations. The WHO has a mandate to provide leadership on global policies, standards, and norms, and to support countries in applying these national norms. SAGE was established by the World Health Organization Director General in 1999 to be the principal immunization advisory group. And SAGE provides recommendations on global policies and strategies for all vaccine-preventable diseases. It's composed of 15 members. There are the World Health Organization divides the globe into 6 regions. There's a broad range of disciplines that are involved. So the 15 members don't all have the same expertise. There's a spectrum of affiliations geographically and diversity-wise, and that's considered very important. The initial term is for 3 years. You can have one repeat term. You can be asked to repeat it. And the actual chair actually serves for 3 years. Oops. So without trying to get into all of the issues, there are lots of other committees that deal with global immunization. There's the Safety Committee. Melinda Wharton here at the CDC is the current chair of that. There's an expert committee on biologic standards. There's a committee that looks at what vaccine research would help move Millennium Development Goals faster, what would help us get to our goal faster. And there are immunization practice advisory committees. There are also regional and national technical advisory groups. The regions elect their own person, and that person comes, actually usually 2 people from each region, come to SAGE and they get input. They're not on the 15 members, but they certainly have input into what SAGE is talking about and what SAGE's recommendations are. SAGE meets, its main meetings are 2 times a year, usually spring and fall. It has lots of working groups, and I'll show you some of those. It does have additional meetings where SAGE meets together over various issues, such as when we had the 2009 pandemic, and also over a decade of vaccine planning. And it's an open forum. They have lots of observers, Gavi, which is the Global Alliance for Vaccines and Immunizations, which provides lots of the money. It does the fundraising to get the money in to allow us to actually get our recommendations down into the arms of children. There's UNICEF, there's secretariats, there's lots of regional people, and then there's lots of other people in there. It usually has about 300 people at the meeting. It addresses questions and that the World Health Assembly may ask us to address, or we know of new vaccines, or we think we need new policies on old vaccines. They are evidence-based recommendations, and they inform a country. They do not say a country has to do something. And in fact, if a country wants to use, for instance, human papillomavirus vaccine, it can, if it's a low-income country defined as $1,500 medium income or per capita income or less, that country has to write what it plans to do to Gavi, and Gavi will say yay or nay. If it says nay, it will say what they want additionally. Oops. I told you old habits die hard. We do grade. In addition to grading, which has been going on for 3 or 4 years now, maybe even 5 years, they're starting to come up with something that I decided not to put in front of you because it's really not yet ready for prime time. But it's basically looking at the side. You can grade a lot of things, and a lot of people who grade or who participate in this sometimes get frustrated that it doesn't tell the whole story. And so the decide mechanism is another way of looking, what's the real impact? And our varicella working group is the first guinea pig, if I can use that word, to try to use the decide part on top of the grades to really say what we think an impact would be or not of various recommendations. All right, so I'll go into this a little bit more, but SAGE makes its recommendations. It has input from lots of people. The recommendations go up to the Director General. I personally do not know of a time where the Director General said no. Now, Art, who's sitting right now at ACIP, was there 3 years before I was, and so he may tell me there was a time when the Director General said no. But these recommendations go out, and then they go in front of world countries, and lots of technical capabilities are provided to countries who want to follow those recommendations. So SAGE was independently reviewed in 2008 and by request of the Director General. And the conclusion was SAGE recommendations have become a necessary step to the introduction and use of vaccines, especially in developing countries, and as a consequence have clear and significant impact. The independent recommendation recommended that the WHO take immediate steps to consolidate and build on the success of SAGE and rapidly disseminate recommendations at the country level and ensure immunization policies are coordinated with a wider frame. I'll get to this because this becomes part of the decade of the vaccines. So, decade of vaccines, in a large extent, was started out because Gates Foundation was willing to give $10 billion over this decade that we're in to moving this along. And the vision is we envision a world in which all individuals and communities enjoy lives free from vaccine-preventable disease. The mission of the decade of vaccines is to extend by 2020 and beyond the full benefits of immunizations to all people, regardless of where they're born, who they are, or where they live. It is a unique moment because there's lots of money. It's not only the Bill and Melinda Gates. I don't know what happened. Oh, maybe. Yeah, there you go. Lots of countries give to Gavi. Lots of other individuals give to Gavi. So Gavi's not only getting money from Gates. And Seth Berkley, who's the secretariat of Gavi, is an incredibly effective fundraiser and has a broad knowledge. He comes from a public health background. So there's a very symbiotic relationship between Gavi, Bill Gates, WHO. They're independent, but it works well. So the goals of the decade of vaccine are to achieve a world free of poliomyelitis. You know, we've missed 2 deadlines. We have another one in front of us, and it's important we meet it. Meet vaccination coverage targets in every region, country, and community. You can't just look at a whole country and say you have 85% immunization with the primary vaccines and think you're doing a good job. That's not going to get it done. Exceed the Millennium Development Goal 4 target for reducing child mortality. Meet global and regional elimination targets. I'll tell you a quick story, which is, given where we are with polio, we were at that point, and where the point we really are right now, we were asked to consider measles eradication. And the answer from SAGE, though there were people very unhappy with us, was that we're not ready to do it. We're not ready to do it for 2 things. We have to get polio done. And 2 is, unless we figure out vaccine hesitancy in Europe, which is very different than the issues of getting vaccine into Africa, and unless we figure out that, we cannot get it done. So the answer was no, we're not ready. It was not saying we'll never set an eradication date, but elimination targets were set for 5 regions. and develop and introduce new and improved vaccines and technology beyond all the money Gates is giving to us, not to SAGE itself, but to vaccine. He's also working on technologies to logistically help get vaccines in. He's working on technologies to develop HIV vaccine, TB vaccine, malaria vaccine. He's not working on it himself. He's given funding in what I think are very clever funding mechanisms, including the $100,000, write 2 pages. Even I would take the time to write 2 pages if I thought I could get 100,000. The Global Vaccine Action Plan is what's going to be used to achieve the 5 decade vaccine goals that contain 6 objectives. I'm not going to go into all the objectives, all the actually quantifiable measures, but it's a collaborative effort by international vaccine community to extend all the benefits of vaccine by the end of 2020 to all the world's children and adults. And it was endorsed in 2012 by 194 member countries at the 65th World Health Assembly. Oh, I should say, SAGE has been asked and has formed a working group to oversee the progress of the Global Vaccine Action Plan. So why has a new vaccine plan been developed for the decade of vaccines? And it's because some of the things that we haven't been able to get done, elimination of measles, eradication of polio, more rapid introduction of really excellent vaccines into countries, more rapid introduction of new vaccines when they're available. And, for instance, it is conceivable now in this decade we'll have a malaria vaccine being put into the arms of children. The previous global immunization vision and strategy, which led the last decade, is now being replaced by the Global Vaccine Action Plan. The Global Immunization Vaccine and Strategy was created as a way to help meet some of the MDGs and some of the Millennium Development Goals, but is no longer adequate to meet what we're trying to do now. So without going through, I'm going to leave this up for a second and just let you look at the difference of focus between the previous plan and the Global Vaccine Action Plan. One of the things that accountability is a huge issue. And I've watched this over the last 4 or 5 years. The countries are being held much, much more accountable for the money that's being given. And I think that's a huge step forward. But you can see the difference between the various plans. They focus on similar things, but it has more breadth and depth to it. Oops. So there's country ownership. They have to own the plan. If they want money, for instance, the low-income countries that are financed by Gavi, if they want money, they have to write the plan, they have to follow the plan. Gavi actually has people on the ground ensuring that that's happening now. Shared responsibility and partnership. It's not just an individual, it's not just the community, it's not just the country. All of us share in this. Equitable access. This was a huge issue when we were in the pandemic, and what developing countries were going to get of the supply of vaccine that was coming off. Integration. It is incredibly important that we not just look at vaccines as vertical programs that don't have any ability to help maximize horizontal health programs that are going on. So, for instance, if we're introducing an HPV vaccine into a country, into adolescents, there are all sorts of health education things and other things, STDs, other things that we can do that coincide with that program that would be very good. And innovation. So the progress to date. You can see that for some of the vaccines, we're at a fairly good level globally, when you look at it globally. You can also see that the most recent vaccines that we've introduced, Hib, PCV, Rotavirus, their uptake is slower. And part of what the decade of the vaccine's about is to make that curve that you see for those vaccines much sharper, much quicker up. So, what have we done since 2010? Through an incredibly complex set of negotiations, deals, thinking, we were able, and we is the global we, were able to get the Indian Serum Institute to make a conjugate A vaccine, meningococcal A vaccine, for 50 cents a dose. Think about that. They then went in, and countries wrote along the African belt, and I'll show you more of that in a second, so I'll wait for a minute. We've done conjugated pneumococcal vaccine, which the uptake hopefully is going to go up a lot faster now, as we actually drive the price down further and further. Dengue, it was not recommended due to a lack of efficacy to serotype 2 and the concern of your second infection may be often worse than your first infection with another serotype. Hepatitis A, we decreased the cost by recommending 1 dose instead of 2. Now, and I'll live through this big time when we looked at rotavirus and the recommendation we made to not use rotavirus vaccine when we first noticed intussusception back in the 1990s was, I will still say, was the right decision for the United States, and we made it as clear as we could in our last paragraph that we did not think this was the right decision for developing countries. But for a good piece of time, this delayed the implementation of it. So when I say that we're very, we like this hepatitis A 1 dose, doesn't mean it's right for the United States or for another developing country. Or for another developed country, those countries will make their own decisions about it. Influenza, pregnant women given highest priority. That's a marked shift from the 2000, and I'll go into that, but from the 2005 previous recommendation that those 65 and older will be prioritized. Rotavirus, removal of the age restriction. I'll show you some data on that. That had a lot of ethical considerations that went into that decision. Tick-borne encephalitis was a very regional, it was a WHO recommendation for regions that have, not for the globe. Yellow fever vaccine, we recommended only 1 dose is needed, that you don't have to get booster doses. That was 2 months after I went to Africa and got a booster dose. Not happy. And use in pregnant and lactating women should be considered based on risk-benefit, not just contraindicated. So if you're in the middle of an outbreak and your mortality with yellow fever is 10 to 30%, you may want to think about giving it. So we'll talk a little bit more about this. So everybody, I think, knows where the African meningitis belt is. 430 million people live there. The population is very concerned about these continuous outbreaks of mainly meningitis. It's not only meningitis. So, the epidemics due to serotype A occur every 7 to 12 years. In 2009, 88,000 cases occurred with 10,000 deaths. In conjunction with the Gates Foundation, a massive immunization program has begun using a conjugated A vaccine and has been initiated in this region for everyone 1 to 29 years of age. We made this recommendation. We made it this is a inactivated, dead vaccine, include pregnant women, include lactating women. About a month later, we got called to a meeting. They were not from the WHO standpoint, but outside groups. Some outside groups were not happy that we were recommending for pregnant. So one of the issues we'll be dealing with in November is how to create a better framework for giving vaccines to pregnant women. In the 6 countries where the vaccine has been used to date, the disease incidence has decreased by 95% or greater. This is the flu. This table basically says how we came to this conclusion. And that is, we weighed the risk groups, we took the risk groups and weighed the feasibility of delivery, the disease severity, the vaccine effectiveness, and the indirect benefit. And of course, we've learned a lot since 2005 about high mortality, high morbidity in pregnant women with flu. So the disease severity was substantial. The vaccine effectiveness from the 4 or 5 studies that have been done looks good. There's an indirect benefit that's substantial, it appears, to infants born to those moms with protection. And so for many reasons, we switched it. The feasibility was a big issue for us because given the tetanus platform, we could just build on top of that. It's not that we don't recommend these other groups, but if all you're going to do is bring in a few million doses of vaccine into your country, then we recommend you prioritize those. So this is the recommendation as it comes out. All the other groups I showed you are lumped together and let countries pick from those if they don't have enough vaccine. Rotavirus. So, in 2009, WHO recommended rotavirus vaccine for infants, included all national programs. Due to the concerns about intussusception, the first dose was recommended to be given before 15 weeks and the last dose by 32 weeks. Data starts pouring in. How many children, because of that restriction, how many children are we not immunizing? So we removed it based on the following data. And these were very conservative estimates. We minimized conservatively the number of deaths averted. We increased probably by almost somewhere around 5 to 10-fold the intussusception rate that we thought was occurring due to the now we're talking about the two new rotavirus vaccines. And so it looks like this. You estimate, obviously there's ranges to this, 43,000 lives saved for 317 intussusceptions. Again, very conservative number for lives saved in the sense that it's probably higher number of lives saved, and a very conservative number for intussusceptions in the sense that it's probably not that high. And we had a lot of discussion about it. And SAGE works by consensus. It does not work by vote. It's different. I told Larry this one time, and he went, huh? How does that happen? And it actually works well by consensus. It actually moves forward after listening to all the input from SAGE members, from other people that are there, including the regions. It moves forward and it makes pretty bold recommendations. So this we recommended for developing countries to take the age restriction out. Yellow fever. This past April at the last meeting, we recommended that only 1 rather than 2 doses is needed to provide lifelong protection, and that the vaccine should be considered for use in pregnant and lactating women based on a risk versus benefit considerations. That's a huge step forward in the sense of we've done this now for inactivated vaccines or for recombinant type vaccines. We had never done this for a live vaccine. And the reason is, if you're in an outbreak, your mortality is somewhere between 10 and 30% if you get the disease. That's a very high mortality. And what we know is after somewhere close to 600 million doses, I don't know if I have this, all right, let me put this all in and then I'll tell the story. What we know is after 600 million doses being given out, we do not know of a single case occurring in a pregnant woman. We do know of 3 cases occurring in moms who are breastfeeding in their babies. But still, it's not saying you have to use it. It's not saying that every instance it should be used. Probably if you're doing a yellow fever campaign on the preventive mode, you might have a different equation than if you're in the middle of the outbreak. But it gives the leeway for the first time to use a live virus vaccine in a pregnant woman. All right. So basically I've just told that story. Okay. All right, highlights on ongoing topics. So we have a working group on the Global Vaccine Action Plan. The first report out from this working group will be in 2 weeks at the November SAGE meeting. We have a hepatitis E working group just formed because China has a hepatitis E vaccine that it is actually trying, for the first time, is thinking about marketing globally rather than just nationally. That's just formed. We have a malaria vaccine group that works in conjunction with another malaria advisory group, and will come back probably in 2015 and make its recommendations on malaria vaccine. Some of you have seen the data. They just recently reported out further data, though there's still follow-up to be done. You say, all right, if you have a 50% efficacy in a vaccine, that's not great. That's true, but you also have a lot of deaths occurring. And so it's going to be an interesting conversation. Pertussis vaccine, for the moment, we've recommended to countries to halt the switch to acellular pertussis vaccine while we see what the real issues are with wholesale versus acellular in protection and effectiveness. I talked about pregnancy enough, and I think I'll show you polio. I think I have that in there. We're working on varicella zoster vaccine recommendations, probably presented in 2014, both on the varicella and the zoster. Very tough issue because we have very little data from Africa and very much worried about an impact if we only get a certain percentage of the population immunized that will shift the age. And we also are working on the zoster vaccine. And all of this in the context of where would countries prioritize this in the midst of all the other things. Vaccine hesitancy working group has been working now for a year. Don't know what the report out is. I will say that the polio group is coming up with some very good methodologies for overcoming some of the types of hesitancy that one might see in Africa or Asia. I don't know where the progress is yet on the types of hesitancy that we're seeing in places like Europe. So they're very different, species. Vaccine nonspecific effects, the question of, there's been some reports out there that if you give certain vaccines, you actually decrease disease and deaths due to other diseases not in that vaccine, and in some cases increase diseases and deaths. That's going to be looked at carefully. All right, so this is polio. Obviously, I'm missing Somalia. I didn't know how to draw this in. So there's obviously a major outbreak in Somalia right now. India has been now well past a year, may even be coming in on 2 years, where it's been polio-free. That's a huge step forward. Had a lot to do with two things, bivalent OPV and accountability. They went in and actually fired people who weren't actually doing their job. There are inaccessible areas right now that are very difficult issues. I mean, polio workers have been killed. We know that there are, in Nigeria in the last year or so, we know that all of a sudden we go into an inaccessible area and we find 211 cases that are compatible but not confirmed and can't be confirmed. So very concerned about this as we try to eradicate polio from the world. Congo outbreak. So these outbreaks are still occurring. The three still endemic countries are obviously Afghanistan. Afghanistan actually looks quite good this year. The little wild disease it's having is being caused by leakage across the Pakistani border. Nigeria and Pakistan, because of inaccessible areas, are still a major problem. All right. So we missed 2 eradication dates for polio, and the global effort is now costing over $1 billion. In 2011, at SAGE's recommendation, the World Health Assembly declared polio to be a global emergency and made the following statement. There are three groups that have oversight over polio. There's the Independent Monitoring Board, and if you ever read the reports, and I recommend you do read the reports, the one just came out, I'm told, today, and I haven't read today's yet either. They say exactly what they think is going on. They don't beat around the bush. And they'll say exactly what they think is going on, how it's going, what's being done well, what's not being done well. So this is more over the polio eradication part. In other words, stopping the disease and getting it out of the world. SAGE's role in this is more the recommendations about, as we progress, how do we use IPV, how do we use OPV, when do we stop using it? It's more technical. There's a fair amount of overlap between the two. And then there's the Polio Oversight Board, which is overseeing all of this stuff. Okay. I talked to you a little bit of what we mean by integration of vaccine delivery with other services. We no longer mean just horizontal programs, perhaps with another horizontal program, combining two vaccines like tetanus and influenza. We would mean come in and talk to pregnant women at the same time about newborn health, how to nutrition, things like that. We're going to get there. It's slow, but we're going to get there. All right. So basically, the problem with the use of in pregnant and lactating women is during the past few years, SAGE has been asked to consider the use of vaccines that, while not always specifically aimed at pregnant women and lactating women, could benefit them and their infants. And examples of those include meningitis, influenza, yellow fever, and pertussis containing. This issue has continued to exist. When I was chair of SAGE, when I was chair of the ACIP, I actually asked and did form a working group to look at the issue of pregnancy. And I thought we did what people were comfortable doing, but I personally didn't think we pushed it enough. So the company, what happens, and will continue to happen until we do something about it, is the companies exclude pregnant women from vaccine trials due to litigation concerns. The regulatory agencies give essentially no data for pregnant women, have little leeway in how the vaccine is labeled. And then pregnancy registries are required, but decades go by and the labeling rarely changes. That's a big problem. Remember, we beat this in drugs for children. In the United States, we overcame this issue by directly going to Congress and saying, here's the problem. 80% of the drugs we're using in children are being used off-label. Drugs aren't being studied in children. This has got to end. So there are various approaches to think about this. At the November SAGE meeting, we're going to think about what framework we can use to move this forward. We do have some regulatory agencies telling us they're very interested in moving this forward. All right, so we talked about what happened in children, and we talked about why we're concerned, and we talked about that. Okay. So I have to acknowledge the Larry Pickering equivalent at SAGE, filled the close. As good as I think, and as much time as I spent with Larry, and as good as I think he is, I think Phil is his equal, and that's saying something. Helen Reese, who's immediate past chair, I've seen a lot of chairs in my day of organizations. I've never seen anyone with the gifts that she has. She was unique. I'll miss her. So let me open it up for questions and comments.
We're open for any comment or question, Dr. Dushan.
Thank you for that comprehensive update. It's really fascinating, and congratulations on the progress that you're making and some of the great things that you're planning. The question I have for you is about surveillance. And I know, just from my knowledge of the measles and rubella initiative, that surveillance is a formal piece of the approach. And you didn't, probably because of time constraints, didn't really talk about that piece. I'm just wondering if you can comment on how that's working out and whether that's integrated at all with what's being required through the revised international health regulations.
No matter, it's better, we're never happy with it. Kate O'Brien is presenting at SAGE in November a session on how to make it better. So there's a working group working on that. Part of it is just, where do you spend your money, right? With rotavirus at one point, some groups were saying you have to do surveillance in every country before you recommend or end it. We don't buy that equation. But do we think it's good enough right now? No. And again, we think that there are ways of improving it. And there are techniques and tools now that are more available by the roadside, if I can use that term, that may help substantially in this.
Dr. Harrison.
Yes, I was curious about the thoughts among SAGE members about, given the success of the A conjugate vaccine, the emergence of serogroup W disease in the meningitis belt, as well as focal outbreaks of serogroup X disease. Where does that, what's the thinking among SAGE members there?
There are really two parts to that question. We were worried and that if we wiped out A, would we see more of something else, right? There's actually Z, there's a bunch of other serotypes there, or serogroups there that are potentially there. And I'm not sure we know yet the answer to that question, okay? As far as I know, they're still trying to get into, if we've done 6, then we have 15, something like that. They're trying to get through this process of getting the A in. And then if we see anywhere near the numbers we saw with A, then I think we'll go back. And there are more and more companies globally, being vaccine companies. India's Serum Institute is one, but China is about to take off as a global maker of vaccines. And so I haven't gotten into, and if you're interested and you're here in town on Friday, I'm talking to Global Division. There's a lot of work being done about market shaping and how you shape the market, how you still work with companies, get the price down and still satisfy them by volume and some other things. And we're going to have a lot of discussion around that because all of this was the A was contingent on getting this vaccine for 50 cents. That's what it was contingent on. And I hope we wouldn't have to go through all of the things we went through to get that done, but that's a big issue.
Dr. Baker and then Dr. Plotkin.
John, thanks for the nice review. I have a question, then one comment. My question is, in a simple way, how do you manage to get people in the developing world to immunize pregnant women? In other words, we make recommendations here in the United States and it just doesn't happen. But how does it actually happen for tetanus, whatever you want to say, influenza?
So PAHO has led the way in this. Argentina and Brazil just reported out that they achieved, in their first year of our recommendation, they achieved only 50%, similar to what the United States achieved. In their second year in Argentina and Brazil, they achieved 90%. And so it's mass campaign, it's communication that fits not only the country, but actually fits the community. It's all about communication, and it's not only communication to the doctors, which helps, don't misunderstand me. I think in the United States, I think most OBs now buy it. I mean, I don't find a whole lot of OBs telling me why are we giving flu vaccine. We make it mandatory in our institution for employees.
Well, but your employees are not pregnant women, and so
Yeah, well, some of
I
them
see
are.
the barrier in the United States based on survey data, not the women, once they're educated, but the providers.
Yeah. So as I say, I think PAHO's led the way in this, and it's matching the communication to the community.
And
your comment?
Well, my comment in general about maternal immunization, I've been presenting the idea to companies for more than 30 years, and so for about the first 5 I heard litigation, which was completely fair. Yeah. And then some wise people said, well, you need to get Congress to do it. And I said to myself, they didn't teach me how to go to in medical school how to go to Congress and get legislation done. So, you know, I don't know how to get the job done. There are some diseases that could be prevented, both mother and baby. Sure. Flu's a great example, but there are others. And I don't see a pathway to licensure of new vaccines that might prevent maternal and baby disease based on efficacy trials, because some of these diseases have a low incidence in the United States because there's other measures, hygiene, nutrition, antibiotic prophylaxis, etc. But in the developing world, the problem is ascertainment and all the noise if you did an efficacy trial on pregnant women. Pregnant women, their life is AEs. So, you know, assuring safety with all that noise, actually getting blood draws from mothers and babies, or even doing blood cultures or viral cultures in babies. Ascertainment of real disease is a big problem. So I don't see, it's nice that the regulatory agencies are smiling, being polite, not slamming the door, all these nice words, but you know, it's a big challenge.
Well, let me just follow up a little bit on that, and to say that the framework, one of the frameworks we might come away with, I don't know what we're going to do in November. This will be the first discussion of it, is to look at inactivated vaccines or separate from live vaccines, right? Look at adjuvanted vaccines and to take that framework and see if we can come up with agreement. For instance, when they came to me and said, how could you use a meningococcal A conjugate vaccine in a lactating woman? I'm going, on what biologically plausible reason are you telling me I can't do that? So that's the framework I'm talking about. In the meantime, when you start down this road, because you push people along the way, and I don't mean that in a bad way, I mean in a good way, and hopefully that we'll move it along. You know, we didn't know how to lobby Congress. We went to the AAP and got some help. Yeah.
Dr. Plotkin.
Well, John, let me start with just 2 quick negative remarks. One is that I did not see a goal for rubella elimination in your list, despite the fact that measles, of course, is being pushed, and we have a great opportunity to kill 2 birds with 1 stone. The second question I have is, has SAGE ever seriously looked at what you could do with $1 billion a year spent on polio eradication and a way of promoting other immunization? Really seriously. I mean, we all want the end to polio, but what could we do with $1 billion that are being spent on what seems to be an ever-ongoing organization? Now, in way of other comments, I just want to mention that there are 2 initiatives that are going on that will start next year in the way of solving problems of vaccine immunity and immunization for the future. One is through the Robert Wood Johnson Foundation that is sponsoring a series of meetings. The first one will be held in February at the Scripps Institute. And the idea will be to attack the problems that we have with current vaccines and future vaccines to produce prolonged and potent immune responses. The second is an initiative by NIH, also which will start next year with meetings looking at the immunological issues with respect to vaccination, why some of our vaccines are imperfect. Also, I would suggest that SAGE look at the vaccine industry as a whole. That is, the issue of supply, the world's supply of vaccines. Where is that going to come from to immunize the whole world's population? And secondly, the issue of where is innovation going to come from? There, as you know, there are many new vaccine manufacturers in developing countries, but by and large, they are not doing innovative research. Meanwhile, the manufacturers in the developed countries are cutting down their R&D. And so we have a real issue as to where new vaccines are going to come from. And I think that the world, which is essentially your committee, needs to look at this issue and how to promote innovation. If it must come from developing country manufacturers, fine. But it's an issue that I think is going to loom very large in the near future.
You make a lot of good points. Let me go back to the measles and rubella. When I was giving a talk to the Global Division on Friday, and I realized that when I had sent this in, I left out measles. We have been working on measles and rubella. In fact, we're the ones who said stop using measles, only use measles and rubella. And in many ways, that makes a ton of sense. And the working group is still active. It's still working on it. It has issues that it's trying to deal with. Some of them are not the simple question, not the question of elimination versus eradication, but can we get enough money to go in and immunize with an MR vaccine on SIA, a supplemental immunization, to do it not just to 5, but to 15. So we're worried a little bit about shifting ages, just like we are in varicella. As far as your polio question, I can't tell you how many times, how many SAGE members have asked that question about, we're spending $1 billion to, right now, eliminate a couple hundred cases a year. But there is such major, I don't want to use the word just political, there's political, social implications of failing at this. That is the reason why SAGE recommended calling it a public health emergency. If we fail this time, we will not be anywhere close. We will have a terribly hard time getting anybody to think about measles eradication. If you asked me back 2 decades ago, looking back, should we have done measles before polio? It's an interesting question, because in a lot of ways it would have been technically easier. I sympathize with the question of $1 billion. I understand the question. I think we have to eradicate the disease, or prove we can. And we are using a tremendous amount of effort and energy to do this. So that's all I can say about it.
Dr. Schuchat?
Yeah, just two quick comments in response to the points of Dr. Plotkin. The polio eradication initiative, in addition to the intense focus on ending transmission, has a component of planning and effort right now focused on the legacy of polio and really planning how to capitalize on the enormous investments and capacities that polio eradication has been creating, and make sure that there's a lasting impact of that for other benefit. And then the second comment is that the Gavi Alliance has opened windows for the poorer countries of the world to apply for MR vaccine in campaigns that go up to age 15. So there's quite a bit of budget going into that, and expectation for hundreds of millions of young people to get measles rubella vaccine in the poorest countries of the world over the next 5 years.
I'm going to try and bring this to conclusion, but I had Dr. Vasquez, Dr. Riley, and Dr. Hinman.
Had a very quick and simple question. When you talk about the expansion of the rotavirus vaccine age limits, can you be more specific?
Well, again, if somebody comes in at 16 weeks getting their first dose, they get it.
So up to 16
Right.
weeks.
So if somebody comes in at 40 weeks to get their third or second dose, essentially in most of the developing countries, it's the 2-dose that's used. They come to get the second dose, they get it.
And do you have a sense of how many children are getting it at the expanded age range?
No, well, again, we just recently made that recommendation, but the surveillance is going on to try to determine the impact of our recommendation.
Dr. Riley.
So I'll make this quick, but I just want to say thank you for putting pregnancy at the top of the list. This is something, obviously, that I mentioned yesterday, and I still think that it's a huge issue, obviously. The only other thing I want to mention, which you probably, John, already know, but Dr. Helen Reese, who was the prior chair, had made a request directly to me through ACOG that we help work with obstetrician gynecologists across the world. And so there is going to be an immunization discussion at the next Federation of Obstetrics and Gynecology meeting in Seattle. I think it's next year. And so there will be some teaching going on at that meeting for all obstetrician gynecologists who attend. And then the last thing is that I think we're all concerned about testing not being, about pregnant women being excluded from, drug trials as well as vaccine trials. And so there is some work being done through ACOG as well as through the Society of Maternal Fetal Medicine, which is high-risk obstetricians, where we are doing the legislative work to now try and build at least some capacity to do some of these things in pregnant women, basically based on what AAP has done. So that is out there, and we are trying.
From my standpoint, that all sounds great.
Dr. Hinman.
Yes, just two very quick amplifications on something. One is that the Southeast Asian region recently passed a resolution calling for regional elimination of measles in the Southeast Asian region. So all 6 WHO regions now have elimination targets for measles. Then Dr. Shuckett pointed out that Gavi has provided support for rubella vaccine. And just in terms of global expenditures, I just wanted to mention that the Gavi Alliance this year will provide $1.6 billion worth of support to the 73 poorest countries in the world to introduce vaccines and to hasten to narrow the gap between when vaccines are introduced in developed countries and when they're introduced in developing countries. Thank you.
And Dr. Reingold.
I just wanted to follow up on what Ann said in response to Dr. Plotkin's comment. There is a discussion going on about how, as polio winds up, if you will, how that infrastructure and resources can be used to more effectively address measles and rubella. And the challenge is to not create another very strong vertical disease-specific program and to do it in an integrated fashion with routine immunization. But that is a discussion that's certainly going on at the moment.
Thank you very much. It was wonderful to just get a sense of what we do, how what we do here dovetails in what's being done globally. Thank you very much, John. We appreciate your time.